institutes, they don't have those. And so that's why it's so important that they stay up to date on the meds and how they work and how they're administered and all those types of things. Any other deviations? This is a great discussion. So processes, procedures, all those types of things are so important. Does this strike you as an environment without a lot of policies and procedures? Possibly. Who knows? Don't know for sure, but that could be part of the etiology of it. Why am I telling you about this case? It highlights a lot of things that we look at. A lot of times in hospitals and facilities, we do call a root cause analysis, which we'll get into in the last session. And when we go through that root cause analysis, we want to figure out what went wrong. And we want to figure out what went wrong, not just so that we can point the finger and say, you did it. And so that's the reason it's always dangerous for me to introduce this concept of culpability in here. But it's important to know so that we can fix broken processes and help good people provide the level of care that they want to be providing. Most failures are failures in systems, not in people. All right, talk briefly about a couple of concepts. So we have Institute of Safe Medication Practices. And thank you for that discussion. That was very effective, I feel like. The ISMP is a wonderful resource for you as a pharmacist or for any other healthcare professional. They're an independent institute. They're not a government entity. Their goal is to advance patient safety worldwide by empowering the healthcare community, including consumers, to prevent medication errors. Okay? It's pretty noble. It's interprofessional, so we have physicians, pharmacists, nurses, etc., etc. Activities. So what do they do? So they'll typically distribute some nationwide alerts. They actually develop error reduction strategies. A lot of the systems that you're going to learn about in the recorded session originated with ISMP. Like other people take credit for what ISMP does. I don't know if y'all know that. And they're okay with that. They just want the ideas to get out. But for example, our do not use abbreviation list from Joint Commission, our lookalike soundalikes, that all comes from ISMP. Also looking at USP, in the next session I'll talk a lot about USP 1066. 1066 is straight out of ISMP guidelines from 5 years before 1066 was first published. So ISMP is kind of that cutting edge of what's safe, what's appropriate. And so if you have a concern, if you're interested in improving patient safety or the job that you take leads you down that path, they become a very invaluable resource to kind of help you see what's coming down the tracks. They also do a lot of work with advocacy. Don't know if y'all know this. You may or may not, depending on how connected to this part of the news you were, but the whole focus on opioids and the opioid epidemic and all of that is very much driven by ISMP and what the work that they do. You're not tested on this. I give you this for purposes of the fact that I'll give you a premature congratulations. You're almost on your APPE rotations. These will come in very handy. Please save these links, bookmark them, or just save the slide somewhere. It'll come in handy for projects on your hospital rotation. Very briefly about the Joint Commission. We used to call them JCO, so you may hear people use that term. It's outdated. I do find it funny that now they call them, the abbreviation is TJC. It's the only organization where the is included in the acronym. I'll lead you to draw your own conclusions as to why they chose to do that. Maybe delusions of grandeur. But anyway, their mission is to continuously improve healthcare for the public in collaboration with other stakeholders by evaluating healthcare organizations and inspiring them to excel in providing safe and effective care of the highest quality and value. They are not a minimum standard group. They actually get organizations to strive to be the best. And the idea being that the better we are, the more we strive for that perfection, although it can't truly be attained, the less likely we are to hurt patients and the more likely we are to deliver quality care. So hospitals are particularly interested in TJC because they can apply for what they call deemed status if they pass their accreditation visit, which occurs every 3 years. Deemed status allows them to bypass a direct inspection from CMS. It's the accreditation team from Joint Commission tends to be a little more lenient and friendly than our colleagues from CMS. I'm not sure why, but that's been my personal experience. I'm sure there's warm, wonderful people in CMS. I just have not found them on inspection yet. Accreditation cycle is every 3 years if you pass. Joint Commission's also started giving accreditation for other organizations too, ambulatory care settings, surgical centers. Our practice over here at UNT Health is actually working our way up to receive accreditation from Joint Commission for our primary care service. There are 4 categories that we are interested in. There's actually many more of these, but 4 that we're interested in as pharmacists. There's national patient safety goals, which I have those listed for you. Medication management standards, so how do we handle medications in the hospital? Life safety, so that has to do with evacuation routes, fire, exposure to hazardous drugs, etc. Environment of care, where we're usually involved in disaster prevention and disaster relief. Don't know if you know this, but virtually every hospital that you go into to do rotations has their own stash of antibiotics for anthrax and has a whole bunch of IV solutions in case Y2K comes a little late, or if y'all even know what I'm talking about on that one. And might be dating myself. And they keep a whole host of things in case of, sarin gas release, all these other things. We used to have 1,000 milligrams of atropine stashed away that would expire every 3 years that we replaced. I provided these for your reference. I'd like you to look at them. I'd like you to get to know them. They make sense. Feel free to reference these later. We're not going to do the activity because I know y'all are eager to eat this food over here. Again, y'all won't be tested on the standards. I'm not going to ask you, is X a standard? Or something like that. This is here for your reference. If I ask you a question about standards, I'll provide you the standard and ask how we manage that. Would like to do this one before we go, and I think, yeah, that's it. So I would like you to do this one, and then we'll have just another minute on the activity. So let's talk in our groups. I want you to go back to the previous slides on Joint Commission and all that types of things. And what types of medications, like thinking about whenever we want to prevent serious safety events from happening, serious safety events being severe harm and death, right? So if we want to prevent a serious safety event, what are the medications or medication classes we should focus on? Some of these will be easy and some of these will make you think. So talk in your groups real quick, and just for time's sake, pick one of these, 1, 2, or 3, all right? And figure out which medications would be most prone to error, which would have the highest consequences of that error, or what human factors may come into play. So let's take just a couple minutes for that, and then we will wrap. Okay, let's go ahead and bring it back. This should have been pretty easy, right? So you probably thought of like 10 things before I even told you to break into groups. Somebody that took the first question, where are we at? A group we haven't heard from. A group we haven't heard from. Yes, coming your way.
We just talked about like benzos, particularly.
Okay, benzodiazepine. Great. Okay.
Because they're extremely sedating or can be.
Okay. Good. So yeah, benzodiazepines are a really good one. They're kind of relevant to the discussion we were having earlier, right? Other thing that's kind of unique about benzos is they're suppress respiratory drive, right? Okay, good. What else? Any other drug classes y'all came up with for the first question? What was it?
What we think about hydroxyzine and hydrazine?
Yeah, good. Okay, so hydralazine being for blood pressure, hydroxyzine being for allergic events. So, yeah, depending on where their heart rate is at the time, you're going to push it in the opposite direction you think it's going to happen. So, yeah, so those are pretty prone to error. So we call those sound-alikes, right? So, or a look-alike, depending on what the product looks like as well. They're both 1 milliliter vials if you're looking at the injection. Of course, the benzos there. So why would the benzodiazepine be prone to error? Sorry, looked at the wrong person. What makes that prone to error, do you think?
Just because the accessibility of them. People aren't
Yeah.
much suppression involved.
Yeah, so the doses are kind of dependent, right? So every person is different. You know, whenever we look at sedating agents, we look at opioids, when we look at other things, every person is very different. And so you have to have that in mind, that your window of therapeutic to toxic is very, very tiny, and it's going to vary from patient to patient. Okay, how about the second question? Consequences of the error. We already mentioned benzos. Opioids is too easy. What else we got? Insulin. Right, insulin's a great one. Actually, it fits in the first two categories, right? So insulin is very prone to error because there's how many ever different kinds. There's even different concentrations. Don't know if you knew. There's a 500 unit per milliliter regular insulin that's out there in the market. It terrifies all of us, right? Okay. How about relevant human factors? So what about human factors as far as looking at drugs that we want to be concerned with? Do y'all know what I mean by that? Yeah, there could be the patient factors, right? But what about like human factors as far as me just engaging with something? So, what classes of drugs might be more prone to that human component? I don't know how to say it without giving it away. I'm sorry. Yeah, there you go. Scheduled drug, right? So abusable drugs, right? Okay, great. All right, so let's go back to our question. So we were talking about this case. So what I'd like to do, we're going to close this out. I need a very brave volunteer that wasn't one of the ones that was taking notes earlier. And then after that, we can leave. Did that motivate? We got a volunteer. You weren't taking notes, correct? You were not one of the ones taking notes.